Yeah. So in the exam, you already passed the written exam. So when you pass the written exam, they know you are in the your knowledge is okay. They want to know if this knowledge can be applied on a clinical scenario. So most of the time it will be a scenario. Nobody can tell you like how you treat inflammatory aneurysm. Do you use a stent or surgery? They don't do that. But they can give you a scenario where you have inflammatory aneurysm. But most of the problem, I think they give you infected more than inflammatory. It could be like mycotic aneurysm, or patient has an EVAR and has got infected, or a water enteric fistula, how to deal with it, patient coming with hemoptysis, something like that, I think.
Yes.
Uh, Carotid patient came with acute stroke. They want you how to deal with this case. They're not going to tell you what carotid like 70% how you treat it. I don't think they ask this question. They ask, okay, patient came with acute stroke, how to deal with it. And they call you patients, they want to know when you do thrombolysis, when you do not do it with the contraindication, when you interfere. So should be scenario.
Okay.
Acute tight dissection is going to give to you, but nobody going to ask you like 5.6 infrared aortic aneurysm, how you treat it. I don't think this is very plain question. So all question should be some trick, something unusual, and especially it has to be an emergency. Because this is where people they want you to see how to react. But in elective cases, always you can take somebody's opinion, so it's not a problem. Always you can call somebody. They want you in emergency situation how to deal with that. And the most important to get patient alive. It doesn't matter how you do it, but the most important to get the patient off the table alive. Uh, the other thing is that, guys, I always tell them two things. First, imagine you are in the exam, you are in the clinic. So don't try to answer what he thinks he wants. Try to answer what usually you do. Like in the exam, you cannot tell them multiple options. Like if I tell you a patient has an infected aortic aneurysm, okay, you can't tell me, okay, I can do like resection with extranodical bypass, or I can do in situ with rifampicin, or I can do in situ with, like bovine tube. This is not an answer because it's not an exam. He wants to know what you do. And whatever you do, even if it's not what he does, but at least if you have to find reason why you choose this way. Like I may do in situ. You may tell me I want to do external anatomical bypass. It's okay as far you tell me why you want external anatomical bypass, or the vice versa. I want to do external anatomical bypass, but you tell me okay, I want to do in situ. Then you have to tell me why you want to do in situ. You tell me like because he has like low virulence bacteria, not much infections, because if I do external anatomical bypass, the stump blow up is very high and risk very high. Okay.
Okay.
So it's very important. This is rule number one. Rule number two, you never say something you didn't do it. If for sure you never did it, don't tell him I do so and so. Of course, like if patient came with a ruptured thoracic of the aortic aneurysms, okay, or like thoracic of the aortic aneurysm, not rupture, because rupture you have to deal with it. If like thoracic of the aortic aneurysm, okay, and you never did it, I mean, if you did it, it's okay. If you never did it, tell him I never did it. I will send it to the specialized center, but I read about it. I can tell you what the step 1, 2, 3, 4, but at least I know you are safe. But if you never did it and you tell me, start explaining to me the procedure, and I can tell in 5 minutes if you did it or not. There's a lot of small things not in the book that you have to do it to know. So I can talk to anybody if you want. I can tell if you did thoracic aneurysm or not before. So if he figure out you never did it and you answer it, then he means that you are a very risky surgeon because in his opinion that you can do a surgery in real life, and if you never did it and take patient to surgery for thoracic abdominal and you never did it, patient will die on the table. So it's okay to tell him I never did it, even in my I was sent to the specialized where they do it, but I read about it. I can tell you the steps as I read it because you have to know about it. You don't tell him I don't know that and I don't know how to do it and I never read about it. This looks bad. So this is an important. Third things, don't volunteer too much information. Just answer the question exactly how they tell you. The answer, just answer. Too much talk doesn't impress the examiner, will not increase your score. It may get you to trouble. And the worst thing, which I noticed that when I was examining there, they have a limit time for the questions. Like you have 15 questions already written. So if you talk too much, then you are at the 10 and time finished, they stop. And they consider the 5 question is not answered. So it'd be against you. So it's not that good to spend too much time answering. Just go specific. Ask a question, just answer exactly the question so he can move to the next one. Because if you go slow or you talk too much or divert from the main button and he start talking about something else, you find like 30 minutes is over and you are in the middle and they don't give you an extension time and they will consider everything after that is wrong. So be careful with that. What else? Again, relax. The most important to relax. Imagine you are in the clinic, patient came. Don't imagine you are reading a book or try to answer a book. You're in the clinic, patient come. I just try to do what you usually do in routine life or what you're going to do in real life. Because like in 2 months, guys, you'll be out in your own. So what you do? So it's okay. I mean, and again, most cases will be like cases you saw. Again, acute stroke, aortoventricular fistula, infected aneurysm, dissection, lower extremity muscle critical limb ischemia. They're not going to talk to you about codification, DVT, venous ulcers. I think this is the most, you may talk about AV axis mesenteric syndrome, something like that is important, you know. So before we start, is there any questions from your side? No. Can you see my slide? Can you see my slide?
Yes, we can see your slide.
Okay, so let's go back to dissection, right? Where's dissection? Let's go to dissection. Here we are. Who's the volunteer?
All volunteer, Dr. Sam.
Okay, well, let's start with this case.
Okay, 55-year-old man without any previous medical care comes in with a crushing chest pain that radiates to his back. He has a normal cardiac enzymes, but gets CTA, chest, abdomen, pelvis that demonstrate an aortic dissection with proximal entry to 3 cm distal to the subclavian artery that extends distally to bilateral common iliac arteries. The left kidney does not enhance, and his creatinine 2.5. His blood pressure on arrival is 190/100.
Okay, so what do you have? What do you think we have here?
Yeah, we have type B aortic dissection with malperfusion of the left kidney and rise creatinine.
Okay, and this nothing. They didn't tell you have to consider is normal. He didn't tell you about the bulge, so you have to consider it's normal. He didn't tell you about lower extremities, if any ischemia, so you have to consider it's normal. So anything not mentioned in the report, that means normal. So don't worry about bowel ischemia. Don't worry about legs, you know. The only thing he has malperfusion is the kidney, okay?
Okay.
So this is a complicated type B aortic dissection,
yes.
Right? So again, first question is he's going to ask, and blood pressure is 190/100. So they call you in the emergency room. So what are you going to do next? You know, this is the most common question.
Next, first I will start impulse control of the patient. Meanwhile, I will obtain the history and I will do the physical examination in terms of upper and lower extremities, peripheral pulses, abdominal examination, and strict control of the blood pressure. We'll start with impulse control.
Okay. All right. But I think because control is just like, you should tell me, like, you know, I see the patient, as you said, they take history. Most of them have to take him to the ICU for blood, because you need a good blood pressure control. It has to be an IV drips, blood pressure control.
Yes.
Because you can't give him pills and send him home, you see? So, so you have to tell me that your next step is to, you know, to the ICU. Then I admit him to the ICU and start IV drips for blood pressure control, okay?
Yes.
Because you have to be aggressive. You have to be aggressive with the blood pressure control.
Okay.
All right. So pressure and heart rate.
From my experience, Sam, did you think they will ask us about the medication and dose, or just to mention that impulse control and
I don't think so. I doubt they will ask you. But I mean, IV is nitroprusside. This is where nitro you use. Nitroprusside is the one you use for, but this is an ICU. But I don't think so. They will not waste time. There's a lot of things they can talk about it, you know.
Okay.
But again, it's important to tell me that you're going to admit him to the ICU, because I imagine you're going to examine him and give him like, when I'm saying everything you don't say it, they don't know. So they're going to imagine you can see in the ICU, in the ER, give him some pills and maybe send him home. You see? So you have to tell me, I examine him, my next step to get him to the ICU and start home on blood pressure control drips. That's it, you know. Okay, so now the blood pressure and heart rate are at goal. So they get into the ICU. Patient continue to have back pain. The RN output is low. The peripheral pulse exam is normal and unchanged. Renal duplex demonstrate a dynamic obstruction of the left renal artery. What you do, likely to do next. So they did duplex ultrasound, you know?
Yes.
I don't think it's very important, because from the CAT scan, you can tell really if the renal is perfused or not. But maybe they want to know the dynamic, if it's like, you know, dynamic obstruction
Or static.
or static. But it doesn't make difference. Renal will be the same.
Okay.
So, and this patient has a renal spherosis, so you have to be quick, you know. So, I mean, for myself, I will not order it, but if you want to order it, I have no issue. Looks like they order it here.
Okay. In this case, I will prepare the patient for OR. I will do from echo and do workup, including labs and everything, and I will review the CT scan to take the proper measurement of the stent graft for TVAR, and I will see the extension of the dissection as mentioned in the scenario to the edx. So I might consider preparing the patient for TVAR with the cover stent, and I will use also a bitcoat technique for covering the distal.
You see, you talk too much, Sam. You see, you jump too much. Again, try to be specific. Go to answer question. Don't answer. He may not talk about bitcoat, you know, technique. Now he talk about it. He may ask you later on. But again, don't volunteer questions, answers.
Okay.
Go to the questions, and then he will ask you, what are you going to do next? You know, what are you going to do next? What kind of stent graft? He may ask you. If he doesn't ask you, that's it. Don't get yourself to trouble.
Okay.
So this way, what you do next, he said, this is a complicated type B dissection. You need to go to the OR as soon as possible. I'll do a measurement, and I'll ask for TVAR, you know, continue my measurement. And that's it. He's going to ask you now how much you're going to cover, what we're going to do later on. But don't talk too much. Let him ask you a question, you know, so you know exactly what he wants.
Okay.
So this is what we do in general, right? Is get into ICU, we get the patient to ICU, control blood pressure. We do a measurement. But how much important to have to be an urgent TVAR, because the kidney is jeopardized now, you know, so you cannot wait till next day. So we have to do it as soon as possible, you know. Okay. So see here, I mean, this is, I think the question is jumped too much. In this situation, I tell you, okay, now explain to me the procedure. So you take him to OR. So what's your plan?
My plan to cover the proximal entry tier of the aortic dissection. This is the main
so
goal.
where do you start from?
Start 3 centimeters from the subclavian artery, and so my extension will be just proximal landing zone to be 2 centimeters in a healthy aortic area. So I will plan to deploy my stent just distal to the left subclavian artery.
And how far?
How far? I will try to cover till proximal to the celiac artery.
Other the celiac artery.
Yes.
How much oversize?
In case of dissection, I will oversize from 0 to 10% only.
Then 10%. All right. So, okay, so you did that. So what do you do next? So, I mean, they explain to you the procedure. Yeah, fair procedure. So explain to me how you do it exactly.
Okay.
Because this is a common question in the oral exam. They want to know the technique.
Okay. First, patient in supine position and under GA. I will prep and drape both groins and also the abdomen and chest. Then I will obtain under ultrasound guidance. I will perform a percutaneous puncture of the left common femoral artery and another puncture in the right common femoral arteries. Then I will pass my wire from this side until reaching to the aortic valve. Then the trauma wire. Then I will exchange it with the stiff wire. If I have a privilege of IVUS, I will use IVUS to make sure that I'm in the true lumen instead of the false lumen. And after exchanging my trauma wire with a stiff wire, I will prepare
There's no IVUS. There's no IVUS.
Okay, I will. In this case, I will advance my wire to the aortic valve and replace it under catheter. Replace it with the stiff wire. And if I have any doubt if I'm not in the true lumen, I might consider
What do you mean by doubt? How you have a doubt? You see, it's the way I give the question because you talk about something, about other thing. You tell me I have a doubt. Okay, so I'm going to ask you what doubt you talk about.
The wire is not passing easily through the aortic arch, and
okay.
If I have any resistance in that. So after that, I will advance my wire from the other side and put a big tail and passing the big tail to the aortic arch, and I will do left lateral. I will change the angle of the C arm to the left LAO 30 degree. Then I will shoot angiogram to identify the anatomical landmarks of the aortic arch, specifically the left subclavian artery, and identifying also confirming the entry tier. Then I will advance my stent graft through the left common femoral until near to the subclavian artery. At that time, I will. I'm sorry, I forgot to mention that heparin to be given after do the puncture. Then at that time, I will ask the anesthesia to try to put the blood pressure in the lower border about 100. And also I will ask for apnea to make sure that proper deployment.
Okay, so finish deployment. What do you do next?
Then I will deploy the stent.
And then?
Distal subclavian. Then I will take out the wire behind the stent and reinsert it again inside the stent. I will do an angiogram again from the aortic arch, confirm that I see the proximal entry tier of the aortic dissection. And also I will complete the angiogram till distally to make sure that there's a perfusion in the kidney.
There's no perfusion in the aorta distally.
No perfusion in the aorta distally.
Mm-hmm.
In this case, I'll consider that I'm deploying the stent in the completely. There is no flow. Yes, I'm concerned that
you see, this is not good. It's not this. He will fail you on this one. I mean, you have the information. You see, again, the whole exam is about how you organize your informations. Because for him, you didn't tell me in any of your steps that you're in the true lumen. The reason why I'm going to put you in the false lumen, you know. If you go easy, it doesn't matter because you can go to true, to false, true lumen, back and forth. It's not. You cannot do that. Especially, glide wire is very dangerous because glide wire very easy to go from true to false, back to true, false. How do you know? So you didn't give me anything to assure to me that you're in the true lumen, And this is the most crucial part of this procedure. Anything else is just, it's just steps. So for him, you may put it in the false domain and it's a disaster. So he's going to say, no, this guy is not, So you have to tell me how to be sure, because this is the most important part in the dissection to be in the true lumen. This is critical in the whole procedures. All the rest, subclavian, everything is not important. So you pass your wire, they done IVUS. Okay?
Yes.
Okay, I don't have no IVUS. Okay? Then you have to figure it out. You may use TEE. TEE can show you, transvisual. Most hospitals, they have TEE. You don't have an IVUS, but most hospitals have TEE. And when we start doing procedure in King Faisal a long time ago, we used to use TEE all the time to be sure in the true lumen, If it's still, you don't have like TEE, then I'll do an angiogram before I start. I put a big tail there and do an angiogram. I'll be sure I'm the true lumen. But the whole thing, you have to tell me something to prove you have in the true lumen, you know? So after you pass your wire, tell him I passed my IVAS. I said no IVAS. I said tell him I get a TE. No TE, I'll do an angiogram, you know? So you have to find a way to convince him you are the true. So you have to tell him that you're looking for, at least you're looking for, so he knows that you're looking for true lumen. But if you don't mention it, he's going to presume that it's not an important step in your procedures, and you may end with a false lumen. And this is a disaster, you know?
Yes.
So in this case, again, you pass your wire, and then I get an IVAS to be sure true lumen. I want to be sure. If it's no, then T. Don't tell him if it's no. If he tell you it's no, tell him I use an IVAS. This is the easy way. If he didn't talk anything, that's it. But don't tell him if no IVAS, I'll do so and so. No, don't volunteer information. Tell him I put a wire, then I get an IVAS to look all the way to be sure the true lumen. He say, okay, no IVAS, then I tell him I use TE. No TE, then I'll get my big tail there and do an angiogram. Try to find, tell him I have to find a way to be figure 100% I am in the true lumen, you know?
Yes.
And then after that, then you change all the things. Then you change the wire, put a stiff wire, then you deploy it. All the step is normal. It just go all the way to the distal, you know? And then you put, as I said, the bare metal stent, you know, the petticoat technique. But if you don't have it, it's not a problem. I mean, you do an angiogram. The most important that you have to do a compression angiogram to look for the renals and SMA and celiac, because sometimes after you close the true lumen, the whole dynamic will change. It may close the celiac. It may close, you know, the SMA. So the most important dissection, because you don't know how dissection behave. After you put your stent, you need to do angiogram to look at the infrarenal aorta, to look infradiaphragmatic aorta, to look at the celiac, SMA, and renals, okay? And here specifically, you have to look for the renal because he has a dynamic or static occlusion of the renal artery, okay?
Okay.
So tell him, if I have a bare metal stent, I like to do petticoat technique because it's expanded. If you don't have it, then I do angiogram, and then according to that, I will decide, you know?
Yes.
All right? So it describes the procedures. This before that. Let's say in the procedure you finish and there is no flow to the renal. So what do you do? Still no flow in the renal.
Still no flow in the renal. I will
Yes.
apply a petticoat technique with the stinging of bare metal stent. And then
There's no petticoat. No. Even you put a petticoat technique and still no flow to the renal.
in this case, I will try to cannulate the left renal artery, and I will put a self-expandable stent.
Okay. Why not balloon expandable?
In the section, self-expandable has a higher resistance in opening the lumen.
Okay. Yeah, use self-expandable in the dissections.
Yes.
Because self-expandable is very stiff. Because that's usually extend all the way to the distal renal. So if you use balloon expandable, you can cut it and get another entry distal. So it's better to use some flexible and nice because you just need to open it. So I will use self-expandable stent, yeah, in the renals. Okay, then you are fine and the flow is fine. So you don't leave the zone until you do compression angiogram and be sure you are, you know, open the renal arteries.
Okay.
Okay. Bus repair patient in the ICU with improved urine output, but he developed chest pain. What's your concern? How would you work it?
In this case,
chest pain.
Yes, I'm concerned of retrograde dissection type A, retrograde type A dissection.
Okay.
And it's considered
what you do?
Emergency. I will take the patient back to OR again. I will just inform the cardiac surgery. The cardiac surgeon.
No, just say no. Why are you taking him to OR? Okay, continue. Okay, I'm just listening. Go ahead.
Okay, in this case, I'm concerned about patient. He has a type A retrograde aortic dissection. I will obtain from him echo to confirm the findings. And if I confirm the findings, I need to take the patient back to OR.
Okay, but you see, I mean, you don't need, again, don't want the information, okay? He said what your workup is. He didn't tell you to get surgery or not. What your workup? But first, you want to know what you think type A dissection is correct.
Yes, I will.
So what you're concerned about it, type A dissection. So what you do? The easiest way to do CTA, right?
Yes.
CT angiogram to look at everything. So I would order CT angiogram. If CT is not, or the kidney is functioning, you worry about it, I'll do a TransH or TE, you know.
Okay.
Yeah, which one is easier? Both I think is acceptable. It depends, because you may tell me because kidney is not good, then I'll do TE. Or TE is faster, you do TE. If TE is not available, then I'll do a CT scan. So it depends. See, in the exam, you can play with that as far you can, you know, define your answers.
Yes.
But the good thing, you have to tell him, I think about type A dissection, and I have to rule it out by CT scan or TE, which one is easier and available. And that's it. Don't tell him take him to surgery and call the cardiac. You don't know. Maybe it's not type A dissection, right?
Yes.
So again, this answer what he asked you and stop is the most important. Okay. Spinal drainage. Remember, say I forgot to ask you. I forgot to tell you why you didn't put a spinal drainage. This is a long case. You should do spinal drainage for the beginning.
Yes.
See, in the case, you forgot to put a spinal drainage.
Yes.
Okay, before the procedures. I mean, it is not a major mistake, because some people, they don't do it routinely, they do it after. But at least like after, also when after they finish the procedure, he didn't tell me you examine the neurological symptoms of the patient.
Yes.
So I may imagine it's not in your brain, and this is dangerous, you know. So either you have to tell me I'll put a drain before, or you can tell me, you know, after the procedures,
I will examine the patient for neurological.
I was a patient, if it's neurological, then I'll put it. But
Yes.
he's going to tell you, but patient will be intubated. It's the problem. It's a major surgery. It may not be extubated. Then you cannot tell. Then it's better to do it as pre-procedure. So as for you, it's safer to be as pre-procedure. So be on safe side. So if I were you, I would say before I start, I'll put a drain to be sure that the spine is protected, you know?
Yes.
So I will do spinal drainage, and then I will examine the patients, okay?
Sure.
So examine the patient, and patient wake up, and he is paraplegic. What do you do?
Immediately I will insert spinal drain, and
No, he's already have it. No, I'm saying we already have it.
I will in this case I will make sure to make hemoglobin, correction of hematocrit, and increase the oxygen for this patient, and I will order for MRI.
Okay. First thing to do is to be sure it's working, because maybe it's kinked, you know. So again, guys, imagine you are in the OR. I want you guys to imagine you are. Try to be practical. He wake up. The first thing I look at the spinal drain. Maybe it's kinked because of positions, you know. And this is very small drain. So the first thing I won't tell him, I will be sure the spinal drain is working. Maybe it's blocked. Then you have to change it, you know. Because the spinal drain is the most important part. So I look if it's kinked and it's working. If it's not kinked and if it's not working, then I'll replace it. If it's working and not kinked, then yes, I'll do as you said. I'll elevate it. First, you have to elevate its blood pressure. The most important is blood pressure before oxygenation, everything. You need the blood pressure is high, so you need high blood pressure. Now you need high blood pressure, and it's okay now because you already covered the tear. So you need a good blood pressure, and then hemoglobin and saturations, you know. And then you have to wait. Sometimes it's irreversible. MRI, I don't think is helpful because MRI is useless. Well, how is it going to help you? It's just wasting of time, wasting of resource. I will not change your approach. I mean, I know it's an ischemia. So what can I do? I have to solve it. I do all this stuff. I think MRI, I don't think that will help. It will not change my treatment. So any test will not change my treatment or help me in decision making. For me, is useless. I will not order it.
Yes.
You know, the same like patient, he's fine. Middle of the night, the nurse call you because he's now become paraplegic. Don't order MRI because MRI is going to delay that. And how's going to MRI, you know, help? So I go away right away. If there's no drain, I'll put a drain. If it's drain, I'll be sure it's working. Then I'll do a hemoglobin, increase saturation, increase blood pressure. And then after all the things, I may order MRI. The only reason I am order MRI to rule out a hematome compressing the spine. It's not because I know this is an ischemia, but sometimes it could be just a hematoma for a drain, which compresses the spine and causing this paraplegia. So not every paraplegia is ischemic. And I
Yes.
saw one case where patient had paraplegia because of the hematoma. So this is the only time, but I do that after I do all the corrective measurement. Don't wait for MRI, because MRI takes, especially in the middle of the night, takes till next day morning, takes 8 hours. And then the spine, it's like a compartment syndrome, they'll be too late. Then even if you drain, it's too late. So the first thing, you be sure that the drain is working or functioning, or there's no drain, you put a drain, then you elevate the blood pressure, elevate the hemoglobin, oxygenation, and then get an MRI. And if you ask you why get an MRI, not to look for ischemia, because you know you have an ischemia, just to rule out for perispinal hematoma from the drain insertion. All right?
Yes.
All right. What else? Let's see the other questions. What the maximum? Okay. So when you get a CSF, when the patient go to the ICU, let's say you put a drain, how do you write the order for the SF?
Okay.
What levels they have to be, and yeah, and how much it has to be?
Okay, it should be the drained for 10 cc per hour, and 10 cc for 10 cc per hour, and for neurological examination every 1 hour, and keep the hematocrit above 70 and the MAB above 90, and also administer oxygen. So
I'm saying the protocol, the nurse, when you get to the ICU, how is the nurse going to have to read your order? What the order right for the nurse for the CSF drainage? Where to put it, what to measure it, you have to tell her that.
Yes, the measurement will be 10 cc per hour, and
look, first you have to tell her she has, because you see, for them this is like a central line. So nurse always they try to level it on the level of the heart. This is the way they do for central line, correct? There is a zero at the level of the heart. This is a spinal drainage. The first thing it tells them, please zero it at the level of the spine, not the heart. Okay? So they have to level it at the level of the spine. So basically they have to put patient flat, put the measurement, the zero at the level of the spine, not the heart, and zero it. Second thing is that it's not 10 cc. No, you have to keep the blood pressure, that means the CSF pressure less than 10. Some people 15, 10 to 15, but usually less 10. Not take 10 cc. This is what we do in the King Faisal because we don't have a good nurses to monitor it. But in the exam, you have to be scientific. The scientific said that you have to keep the CSF pressure less than 10. So you tell him, I'll write to the nurse, level it to the level of the heart, the spine, keep the CSF pressure less than 10, neuro exam every 2 hours. If patient develop anytime, the same also, keep hemoglobin more than 9, some people, they said even 10, saturation more than 95, mean blood pressure more than 90 to 100. But the most important is that, and if patient develop any neurological symptoms, you tell him open to the gravity. You open right away and then she call you.
Yes.
Not to, so tell her if you got any neurological symptoms, please open to the, to the gravity, just open it completely and call me to come for assessment, So this is the way we deal with the CSF.
Okay. And in case
so how much you can drain, but you tell her don't drain more than how much? This is the question here. How much you can drain more?
Drain more, not more than 10 cc per hour.
No, 10 cc is no more. You can up 20 to 25, up to 20.
In case
20, 25.
Yes, in case emergency, we can increase it to 20. Yes.
No, what I'm saying is that when you write to the nurse, because she's going to drain depend on the pressure, right?
Yes.
So the pressure may drain more than 10. She may drain 20, 30 to get the pressure less than 10. But if you drain more than 20, you get herniation. So you have to tell her, okay, keep the CSF pressure less than 10, but do not drain more than 20 cc per hour.
Okay.
Okay, you have to write that. This all has to be in protocol. Because nurse, she doesn't know. She's just going to treat your protocol. If you tell her, okay, keep CSF pressure, maybe she just keep draining, and next day patient got a severe headache or herniation. So you cannot drain more than 20 to 25 cc per hour because you get herniations too fast, you know.
Yes.
And second thing, CSF, if you come next day and patient has no neurological symptoms, what do? You take it out?
No, I will, in this case, I will open
In general, like you do next day, patient neurological completely free, no symptoms, he's moving his legs, sensation is normal. Do you take the CSF drain out?
No, I will observe for, I will do trial CAB, 4 hours, and monitor for any neuro changes.
And it's nothing. In 4 hours, nothing. You take it out.
After 40, if it's stable more than 24 hours, I will consider removing the drain after capping.
Yeah, usually drain should be kept at least for 2 to 3 days. 24 hours is still early because they get the delay ischemia sometimes. So if you put CSF drains, you have to give at least for 2 to 3 days, 48 hours at least. So even if you come next day normal, don't remove. Next, give him 1 more day. After 48 hours, nothing, then you remove it. Some people, they like to do 3 days.
Yes.
Okay. So this is a commitment for CSF, at least 2 to 3 days. What else? I think that's all for CSF. What if ICU is a colio and drain now it has a pink thing? Pink. Just some pink color in the CSF. What do you do?
I will come to see the patient and evaluate for the drain. Most probably, maybe he has some tissue discharge around the drain. It is not a major concern.
So again, yeah. So again, pink is not a major difference. But what if you see a blood?
Yes.
What if he said you see a blood, not a pink?
I
you see blood
blood
coming out.
Yes, I will clamp the drain. I will order for urgent stat CT brain to roll out any hemorrhagic.
Correct. So this even should be in the order in the ICU. When it's in patient to ICU, one of the orders say, if the CSF turn bloody, turn it off and call me.
Yes.
Because they can get herniation, because if it's bleeding, can get herniation. You see? Because imagine, nurse to call you, sometimes it takes half an hour to call you. Maybe you don't answer her, you're in surgery. So you may not answer her in 3-4 hours. And by this time, patient may be like dead. So this should be in your protocol. So the protocol, again, the way you write it, drain CSF to keep the CSF pressure less than 10. Don't drain more than 20 cc per hour. If it's turn bloody, please turn it off and call me.
Yes.
Okay? This is the way it should be the order. What if calls say, oh, we talk about it. What the follow-up schedule on this kind of patient?
And this kind of patient, I will order for this patient CTA after 1 month. Then I will follow up him annually.
And what? Sorry.
I will follow up the patient annually with CTA.
So 1 month and then annually? No, it's too far. Usually do 3, 6, and then 1 year, right? This is all are follow-up the same. So yes. I do a 3, 6, and 12. But if you do like 1 month, then I go to 6, then year, you know. Some people do 1 month, some people 3 months, and then 6, and then 1 year, okay? But you can't jump from 1 month to 1 year. It's too far, first year. What if in order to obtain adequate proximal seeing zone, you need to cover left subclavian artery? What do you do?
In this case, in case of emergency, I can cover the left subclavian artery, and I will observe the patient for any signs of upper limb ischemia or dizziness or something related to the vertebral arteries. In case of elective, I will consider to do carotid subclavian bypass before closure of the subclavian artery.
You see, again, in the exam, he's not asked you, he asks you specific case. So don't give him multiple options, elective and emergency. He's talking about this case, you see? So in the exam, don't tell him if elective and emergency. We're talking about emergency case, right?
Emergency, I will cover. In emergency, I will cover the subclavian artery.
Right, but I don't feel comfortable to leave with subclavian artery occlusion in the type B dissection. In the trauma, it's okay because you just cover 10 centimeters. In the type B dissection, I think it's very dangerous because we know left subclavian artery is very important for the spine.
Yes.
and you already covered all the spine down, I think it would be a very high chance of paraplegia. So if I will not leave always covering subclavian. I will do either site of fistulation, chimney, or cut subclavian bypass. You know, because it's not a rupture. I think it's emergency, but not like emergency is patient dying. You see, it's different. When patient comes with a rupture, aneurysm is different from an urgent. This is an urgent, not an emergency. So in this scenario, no, I will not like to left subclavian without revascularization in type B dissection. In trauma, I agree. In trauma, I will just cover it. I don't care. But of course, you have to tell him, I have to look for the vertebral artery, you know?
Yes.
If you decide not to reconnect it or whatever, revascularization, then you have to look at the, be sure it's not the dominant one.
Okay.
But I will not leave that OR. I think if in this case, either do in situ or the chimney or the cut subclavian bypass before I leave. If I have to get
as a sequence, I will do TVAR first, then I will go for carotid subclavian bypass, or do the carotid subclavian bypass first, then followed by TVAR. Sorry.
Clinically, you should do the bypass first, really, unless it's a patient for some reason urgent or something like emergency. But if it's not, you have to do, because by that time, if you cover it, by that time you do bypass, it may take you an hour. If he has a major vertebra or spine, it may be really ischemic, long ischemia for 1 hour. So I'll be worried about it. So, I mean, it depends on the consequences, how's the situation, how's the patient, how's the urgency. But if I have a choice, I will do the bypass first, or chimney, or whatever I want to do.
Okay.
Or use a branch TVAR now. We have a lot of options now. But I don't feel comfortable to close subclavian without bypass or revascularization in type B dissection. Okay?
Okay.
What else? So, okay, let's get somebody talk about, I don't have a scenario, it's the only scenario, but let's talk about uncomplicated. Let's get somebody else talk about uncomplicated type B dissection.
Dr. Samuel, may I ask you, please? I have 2 questions.
Yes, go ahead.
First question, what if disaster وعمل deployment في الفالس lumen وصار occluded للأورطة. At that time, what should we do? أنا أقول لك لا قدر الله يعني الله لا يقولها.
No, it happens. And it's a good question. What will you do?
والله أدعي وأدق على دكتور حسن.
No, it's simple. It's not simple. I mean, yes, I mean, you can, I mean, if you have a good expertise, you have a lot of way to go recannulate it and go down back to do lumen. But if it's like you don't have much experience, the best way is just to auxiliary by FEM. Then you get the flow from down up.
Okay.
So I would just do auxiliary by FEM very quick.
Then
is it possible to go from the right brachial from the volume
right side
and put another TVAR stent?
No, I see. Yes, of course, you can go and try to recannulate from from true to the false. But I'm saying, depending how much you experience in the vascular. But let's say you are, tired, no other device. Maybe you have the only one device, maybe because you need other extension. Let's say you don't have other extension, because you only have one piece left and you already used it. Okay, and you're already tired or whatever. The quick question, the quick answer to get off the trouble, because this, when patient on the table, your priority is to get the patient off the table alive. Always you can come back and fix everything. So it depends. I mean, if you're in a center where you have a good endovascular skills and, you have extra device on the pieces on the table or on the side, yes, I'll try to go again from true to the false lumen. You go back and you put another one extension to the true lumen. It can be bad. But if you don't have it, don't panic. Just do auxiliary by FEM, get him off the table, or you can come back and fix things. This is what I'll do.
Okay.
Because imagine when it's occluded, this is a time bomb, because now no kidney flow, no renal, no bowel, so by the time, even if you want to wait for another device, it takes an hour to get it from somewhere else. So you see, so in the situation, time is important. I'll do auxiliary by FEM quick. until later on, the next day you can bring him back and fix everything, and you can close axilla by film. It's not a big deal. It's not a major surgery, you know.
Fair enough. Second question هي تناقشنا احنا والشباب فيها آخر مرة. إذا if I have left iliac occlusion, left lower limb ischemia only, is better to do TVAR or just FEM by FEM and wait the patient till in the subacute phase to deal with the...
Good question. Yes. Well, what do you think?
واحنا الشباب مشينا على انه FEM by FEM FEM باي باس وكيب ذا بيشنت امبلس كنترول ثيرابي وننتظر انه البيشنت يطلع من انتظر period of
subacute stage. Why you want to go to subacute stage?
Because the complication of aortic dissection is going to be
lower.
Better, lower, yes.
And I think one of the options to Saber, we discussed about it. You know, once I open the femoral, the TVAR will not take that much time, so I can do both. I can do TVAR and FEM at the same time.
No, that's not a good answer. No. But let's discuss it. Let's discuss it so you know the answer by yourself. I don't want to give you. I don't want to give you the answer right away. So you said you want. I'm just to figure out why you wanted to stay to subacute, because you said the mortality is less if you do in subacute than acute. Correct?
Correct.
Yes.
Which is true. It's true. I'm not saying it's true. But this is for what? No, I didn't finish my question. But this is for what? When you have to wait for uncomplicated until subacute stage, in what scenario?
If the patient responding to impulse control, so we can wait at that time. If he don't have any complications.
So what we call this one? What we call this one?
High risk group patient, not complicated, but high risk group.
Okay, so uncomplicated type B dissection, correct?
Yes.
So this is the only one you wait to subacute, but when you have a complicated type B dissection, it's no time for waiting. You see, this you talk about 2 weeks to wait. This when you talk about uncomplicated type B dissection. But when you talk about complicated type D dissection, you have to do it as soon as possible. Don't wait for 2 weeks. So when you have albalic ischemia, this is a complicated type B dissection. You have a renal ischemia, bowel ischemia, uncontrolled pressure. This become a complicated type B dissection. Then this rule will not apply. Then forget about this rule. So in this scenario, we are talking about complicated type B dissection. So I will not. No, I'll go put TVAR right away. Okay. Unless if they tell me you're in the area very far, you don't have a TVAR, you have to transfer him to another center, like you are in somewhere in the north, and you don't have access to TVAR, you want to transfer him to Riyadh. It takes about 8 hours. Then yes, I'll do FEM to keep the legs alive, and then I'll ship him right away to the place where you do a TVAR. But if you have an access to the TVAR, no, I will do TVAR first, and then we'll see, because most of the time when you do a TVAR, this will open by itself. If it's not open, then you decide either you do a petticoat technique, or you do bilateral iliac stent, or you do FEM bypass, whatever to get the blood down to the legs. But the first thing, you have to close the primary entry. So don't worry about this 2 weeks rule. This is only for uncomplicated. Complicated, you have to do it as soon as possible. Is it clear?
Fair enough, sir.
Okay. What about bowel ischemia? The same.
I think same.
Yes.
Okay.
Plus minus SMA stent. The same TVAR plus minus SMA stent.
Correct. But let me tell you a difficult one now. If patient came with a type A dissection and bowel ischemia, what do you do?
SMA stent and cardiac surgery for fixing type A dissection.
So you do the bowel first.
Yeah.
Yeah, this is the only one you do the bowel first, because if you do the ascending first, by the time you finish the bowel will be dead, then patient's dead. You know? So because type A dissection is surgical dissection, takes about 7-8 hours, and by this time the bowel will be dead. So the only exceptions is type A dissection. Type B dissection, no, because the moment you put the TVAR is very quick. The moment you put TVAR, you open the false lumen or true lumen, then most of the time the flow to the bowel come back. So it's okay. So the only time you do intervention in before fixing the tear is if you have a bowel ischemia with type A dissection. If you have leg ischemia, it's not a big deal because leg ischemia can wait. Or what you can do, you can put a catheter, you know, in the femoral artery, get perfusion from the perfusion, you know, machine, and perfuse the leg until they fix the ascending aorta. This other option you can do it, you know. But bowel, you have to fix it first. All right. So uncompleted type B dissection. What are the risk factors? They may ask you about it.
السؤال لا
If you have uncompleted type B dissection,
اوكي
what you do, if they give you a scenario patient uncomplicated, he came with blood pressure, high blood pressure, and pain. Okay, and the CAT scan and no bowel ischemia, everything is fine. So what you do in this scenario? They give you the same scenario, but there's no kidney injury. So what you do?
Again, Dr. Samer, we'll start with the impulse control medication and admit the patient in ICU.
Okay, and next?
And next, we'll keep following the patient, seeing if he developed any high risk feature or not during the follow-up.
Okay, and this is quite tricky what you mean by follow-up, because this risk factor, I have to see it in the beginning when you see the CAT scan. When you do all the CAT scan, you look for this from the beginning,
Yes.
okay?
Yes.
So when patient came, you can do blood pressure, and then you look at the sign off to decide, do I need to do him or not, you know?
Yeah.
This one, you went to wait for 2 weeks, yes, until you get him off the acute stage. But this is only if blood pressure is controlled and pain get away. If blood pressure is not controlled and still have a pain, this is considered complicated. It's not uncomplicated. It's complicated type. It has to be done. So you give patient 2-3 days. If blood pressure is not controlled, or if he still have pain, then you have to fix it right away. Don't wait for 2 weeks.
Sorry, Dr. Samer, but we just give the patient, I think, 12 hours to see if he is not responding to the control of blood pressure and the pain. If he's not improved within 12 hours, I think
12 hours too short. I know somebody written this for it. I think for me, 12 hours too short. Yeah, take some time blood pressure, because this patient's chronic blood pressure. It's very hard to get him down very quick. I give him like a day or two, you know, unless it's, you know, and pain. I mean, of course, you have to see some improvement.
Okay.
They tell you a little bit better, the blood pressure start coming down, you know. But if it's like after like next day, blood pressure is still like 180, can control, then I'll do him, yes. But if it's like 200, now is 180, now when it's coming down, then yes, we just give him some times, you know. Correct. And his blood pressure his pain coming down, then I watch, and it's no time definite. But reasonable is 2-3 days to control everything. Give him some times, you know. If it's not, then you stand him. Yeah.
Dr. Samer, what about the surveillance? طبعا mentioned in some books that after admission CT scan, then repeat the CT scan after 48 hours, and some mentioned that after 1 week. What do you think about the surveillance? And
I mean, this is no protocol. Everyone is different, but most people, they like to do it before. Are you talking after EVAR or without?
No, not after EVAR. Uncomplicated type B dissection.
Uncomplicated.
Yes, uncomplicated. How will do the surveillance of the CT scan during the admission?
During the admission. As I said, some people, they do it after 2 days, 48 hours. Some people do it before discharge, you know, within a week. So really, it's not, I don't think it's an obvious, you know, I will look at him. If he's improving, you know, his blood pressure went down and pain went down, I will just wait until he discharged, or maybe after 2 weeks, I will repeat a CAT scan. But if he's still hypertensive, he still have a pain, they like to see what's going on, I'll do CAT scan earlier. So again, it's nothing like definite. It depends how the patient behave after, you know, the dissection in uncomplicated type B dissection.
Okay.
Like, I mean, if patient fine after like 2 days, his blood pressure well controlled, he become pain-free, why need a CAT scan? I just send him there maybe after like, you know, 4 weeks, I'll repeat a CAT scan. This is the time I'm going to do subacute stage. Then I'll do a CAT scan maybe in 3-4 weeks. And then after that, I'll decide on treatment. But if I give him his blood pressure not controlled, he still have pain, he's not behaving right, then I'll do CAT scan for 8 hours or before discharge. So all depends how the patient behave, you know. Yeah. Any other question about dissection?
شباب أحد عنده سؤال؟
I hope it's clear إن شاء الله.
إن شاء الله.
Yeah, I think guys, you can get yourself. But again, the most important, guys, in the exam, please be sure the wild trolomine, because this is they looking for that. In my opinion, it's the most step in the procedures, you know. Or just tell him like, you know, I pass the wild and I want to be sure that I want to be sure the trolomine. Then he may ask you how you do it. But just have to mention to him that I want to be sure that the trolomine, you know, the wire in the trolomine when I advance it before I deploy the TIVA, either by TE or IVAS or angiogram, whatever you think is, you know, feasible. You do it. Oh, it's 4:30. Oof, been an hour. You want to do a venous now, or you want to do it later on Monday? What do you want to do, guys? You want to do a venous case? You told me you'll do. I want to do a venous.
Yes, we can do, Doctor.
Yeah, where's the venous? Venous. Venous ulcer, you said. Okay, who want to take it? Let's do it quickly, this one.
Yes, I can take it, sir.
Okay.
Okay, 60-year-old woman referred to the clinic with the wound on the middle left ankle with associated swelling. This wound had been presented for over a year, and she is currently seeing a wound care for it. The wound initially improved with debridement, but the wound care nurse said that it's not completely healed. She is obese, diabetic, and non-smoker. She's denied any history of claudication, wrist pain, or prior surgery.
Okay, so we're just talking about venous ulcer, right?
Yes, sir.
No history for claudications, wrist pain, or prior surgeries. Okay. So what do you do next? Is a question. Is a most common question. What do you do next?
Okay.
Yeah.
I will start taking a detailed history regarding the wound ulcer, exactly when it can happen, any history of coagulable diseases, or any history of oral contraceptive pills that she was taking. Then I will do full vascular peripheral examination for the limb. Finishing by asking for stats lab, CBC, chemistry, coagulation profile, renal panel, and duplex ultrasound.
Venous or arterial?
Venous, sir.
Okay. Some people they order both because unless you have a very good pulses, you know, because you're going to put a compression dressing, and if he has a vascular disease, you know, it's a problem. Even though I see arterial as a venous disease, but usually it's the books they tell you always you have to look for arterial also before you apply, you know, because you do an ABI to be sure. The ABI more than like at least 6 or 7 to apply the compression dressing. Okay, so we do. So, but the most important, the question asked about DVT, I don't know if you mentioned that or not. The most important, does she have a DVT or not before? Is the most important, you know, question.
Yes, I didn't mention it, sorry.
Yeah. Okay, yeah, DVT is important. There's no other parasympathetic history. The one's about 5/5, puffy red pace, and no evidence of infection and rage. Beta pulse are palpable. Twice, that's it. The left leg has one beating edema and some lipodermatosclerosis with one texture. What you concern about? Venous ulcer, right?
Venous ulcer, sir.
Yeah. Venous ulcer, so you did the venous ultrasound, no DVT. But she has deep reflux in the femoral, popliteal, and superficial reflux in the seventh vein from saphenofemoral all the way to the ankle. No reflexing perforator. EBI is normal. See, they did EBI. Even though pulse is there, they do a EBI. I don't know if it's any important, but maybe in the exam you should do it, you know. Because again, they always, when you talk about venous ulcer, they want to be sure that you have good circulations. But he thought you have a palpable pulses, but I don't know. I don't think it's any important. If it's no palpable pulses, I'll get ABI. But it has palpable pulses. I don't know if CBI is important. Anyway, so how do you interpret this finding and what you will do next?
Well, this patient had venous ulcer with reflux in the superficial system. So I'm gonna prepare my patient for
No, both. We have both.
Yes.
Deep and superficial. You see, they
Yes.
said. So we have
Yeah.
reflex in the deep and superficial, both. Okay.
Yes, sir. So
But
I'm
no
gonna.
reflexing perforator. Okay.
Mhm. So I'm gonna plan the patient for AVLT for the great saphenous vein.
Ablation.
Yes, sir.
Only? What else?
With compressive dressing for the patient and wound care.
Okay. When you need compression dressing, if you're going to do the saphenous vein, when you need compression dressing, you're going to ablate it, right? So you're going to close the reflex.
Yeah, I will start my compression even before ablation, but with taking
But I say
plan.
but after you do ablation like the saphenous, you still need compression?
Yes, sir. I will complete compression for the patient.
Why? Why?
Because she had deep vein reflux also.
Correct. So she had the venous reflux. This will not be treated, so you still have to have compression. So I will do the compression dressing, and then I will apply the femoral. The whole saphenous vein.
Yes.
Okay. What do you use? What do you use? Well, let's go through the question. Maybe it's better. On a boat. Okay.
Yeah.
You see here they did the compression dressing first. First they give her like 3 months of free compression dressing. I don't think it's a good idea. I don't agree with that because you already have a reflex. So why need to wait for 3 months? I think it's wasting of time. You see?
Yes, these things that also we discussed with Shabab كمان تكلمنا, we talk about these things. We said if the patient have great saphenous vein reflux, I think we will treat the patient even.
Yes.
Yeah.
I'll do both. I do compression dressing and I'll do right away. I will not wait for 3 months. No.
Okay, great.
So I will do ablation and then I'll do the compression both. But waiting for 3 months, why? Already you know the problems, Anyway, so they wait for 3 months, so there's no changes. So what your next step? You're going to apply the saphenous vein, correct?
Yes, sir.
Some of this question is not good, Patient want to know her option of treatment. What option of treatment we give them?
We can give the patient the ablation. We have radio frequency or radio frequency or laser. We have also venous seal can be used for the patient even
So
on
what's the
surgical.
main category you taught? What you say? What do you name it? You can thermal or non-thermal, right? Thermal and non-thermal. This is the way you say, because radio frequency and laser or thermal. When venous seal is non-thermal. So usually we categorize to thermal and non-thermal, okay? Or surgery, right? Surgery is still an option.
Surgery. Yes, last
So what
thing
are options? Surgery or thermal or non-thermal treatment, right?
Yes, sir.
Okay. So how do you decide which one? When do you decide surgery?
If there is contraindication for the thermal or non-thermal intervention, I will go with the surgery.
Which are the contraindication?
If I have less than 0.8 distance from the skin, if I have thrombophlebitis, peripheral thrombophlebitis, if the patient have, tertious great saphenous vein, if the diameter of the great saphenous vein is more than 30 millimeter.
Okay.
Let's
talk about all these three. First one, if it's superficial, I don't need the contraindication because you can do non-thermal. Okay. Thrombophlebitis, I don't think it's an indication for surgery because the same thing, you cannot get it with a laser, you can get with a surgery because you have to get to your wire throat. If it's tortuous, most of you're not in the greater saphenous vein because greater saphenous vein should be straight, when you see tortuosity, most of you are in the branches or anterior branch or something like that. So the only indication really for surgery, if you have aneurysmal dilatation, like big, like more than 2 centimeters, like 2.5 or 3 centimeter, then I'll do a surgery. Other things, everything I'll do thermal or non-thermal. Now, when you do thermal or non-thermal, as you said, depend on the depth from the surgery, from the skin. If it's deep, thermal is better. If superficial, then non-thermal is better, correct? What else? When also you like to use non-thermal?
I think Dr. Saber in the leg.
In the leg, it's below the knee, correct.
Yeah.
So below the knee, if you want to treat it, use non-thermal because the sural nerve is very close. Then use non-thermal. So non-thermal if it's superficial or below the knee. Thermal, it should be deep, and you have to stay above the knee. This is all things about it. What's the common reason surgeon could recommend non-thermal? We talk about it. Are there any cases where either of these endovascular category could be recommended? If you have an aneurysmal dilatation, right? We talk about it.
Yes.
You said it's deep, 8 millimeter. What do you recommend? Thermal. Stage, okay, scapular procedure. Okay, so how you do the thermal or nothing, whatever. How you do the procedure?
Well, the
Let's talk
patient,
about the thermal one.
okay. Patient gonna be in supine position. We're gonna drape her full left leg till the groin region. Then we'll place the patient and head up gradually. Then I will start my puncture distally in the great saphenous vein as much thermal as knee level. Then
Okay.
micropuncture. I will introduce my sheet over the wire, 6 French sheet. Then I will introduce my probe of the thermal till I reach the junction of the saphenofemoral junction. Then I will start my Thomason solution injection around the whole great saphenous vein to the level of the junction. Then I will place my probe around 1 inch away from the junction. Then starting doing my ablation above proximal till I reach distally, removing my sheet and complete my ablation till the end. Then I will apply compression for it and finishing my procedure with compression dressing.
Okay. I'll tell you first, I think, if I'm not correct, it's 7 French, not 6 French, unless there's different devices, but most devices use 7 French, the first things. Second thing, Thomason, you see, this is the moment you put Thomason, you cannot see the tip of the catheters because all this fluid, they obstruct your images and the vein will be collapsed. So you have to position your catheters before giving Thomason. You did the opposite. You said you put your catheter all the way up, you gave Thomason, and then he said, I pull it back. You cannot do that because you cannot see it. So you put your catheter all the way to the tip, and you pull it back 2 centimeters, and then you give Thomason. Okay? This is very important because, again, the moment you give Thomason, that's it. You cannot see anything because everything is collapsed, everything is stuck together. So it's very hard to see the tip. Okay? And then you do ablation, as you said, by laser or radio frequency all the way until you get out. So the rest is just straightforward. Okay.
Yes, sir.
Follow up at the end. Yeah, very important. You tell me. You should
do
forget to tell me.
duplex.
You do
I
two
will do
things.
duplex,
Yes, you have
duplex ultrasound to see the junction.
not the junction. No, you do duplex for 2 things. First, you be sure there's no flow in the saphenous vein, and you do it in the femoral vein. Be sure no DVT. So while in the table, after you finish, you get the ultrasound. You go to the femoral, you check it. You be sure no DVT, and you go to the saphenous vein. You check the flow. Be sure it's occluded. So you have to do it before you leave the OR. Okay.
Yes, sir.
It's an important step in the procedures. You did follow-up follow-up duplex showed the thrombus extending to the common femoral vein, obstructing 50% of the lumen. What do you like to do? So what happened?
I get hit, so grade 3. So I will keep patient on anticoagulant and follow up ultrasound duplex 1 week.
How long you want to keep the anticoagulant?
as much there is the thrombus there, I will keep it for even 3 months, 45 days to 3 months, as I remember.
How you decide?
I will repeat the
No, you
ultrasound double X-ray.
Okay. I mean, it depends really. It depends. Some people, they said, as far you are very close from the common femoral or inside the common femoral, you know, within 3 centimeters, then you have to treat it like a DVT. Then you have to go for 3 months. You know, some people, they look at that as thrombophlebitis. Thrombophlebitis, you treat it, you know, only for 45 days, you know.
Okay.
So I think what I will do, I'll treat for 45 days and then repeat the ultrasound. If everything's fine, I'll stop. If it's not, then maybe I go for 3 months.
دكتور
But
سامر
this
What?
is like controversial. Yeah, go ahead.
بس بعد اذنك على الاي هيت 2 اللي هو less than 50%. What you mentioned in the box, we could observe the patient, but do you think we better to give him prophylactic anticoagulant?
This is more than 50%.
Yes, in case of E hit 2, less than 50%.
If less than.
Yes. No, this area of controversy.
Well, the problem is the books, remember, books is just an opinion of somebody. Is the way I always look at the book, is somebody's opinion, you know. I mean, because always you can see some people, they said if extend to the femoral, even if it's a flush occlusion, they consider it as, because if you have a thrombophlebitis, let's say, okay, forget about it. Let's say you have thrombophlebitis, okay? All the way to the junction, how you treat it? Forget about this case. They tell you, give you a scenario, patient had thrombophlebitis, extend all the way to the femoral vein, to the flush, to the femoral vein.
Anticoagulation, sir.
For 45 days.
For 45 days, correct?
Yes.
Yeah, you see.
Yes.
Sometimes it's difficult to know what people are saying. You know, I mean, sometimes it's confusing. The reason why in the oral exam, try to be flexible, and you can discuss. The good thing about exam is not like a written black and white. You can discuss, you know. You can tell him, okay, some people, they said say, and some people say that, but I feel more comfortable. You can tell him, okay, if that less 50%, tell him, some people said, you know, you just observe it, but some people, they consider like thrombophlebitis, better to give 45 days. For me, I prefer to give 45 days. Even in, like, I asked some people, even with the normal ELT, people give prophylactic for 5-10 days. You know, they give anticoagulants.
Yes.
Some people,
Yes.
they do that.
Yes.
So it's nothing like black and white. But for me, thrombus all the way, I think I'll be concerned. I prefer to be on the safe side. So for me, I would treat it as 45 days, it'd be like ultrasound. If it's everything dissolved, that if it's not, I'll go for 3 months. Yeah. Always better to be on the safe side, you know, especially in the exam, you know. Yeah.
Dr. Samir, I have a question. What if we have a patient with thrombophlebitis and extending to the saphenofemoral junction, and we treat it with 45 days with anticoagulation, and you repeat the ultrasound and still the thrombus is there? You will
usually
continue
it is enough. No, this is different. Thrombophlebitis by itself, this is thermal, it's different. Because this is a thermal injury. So this is injury to the intima from the thermal.
Okay.
So this one is a bit different. That's why this one I like to treat like a DVT, because you already injured the intima. You know, from the heat, it went all the way. The other one is just thrombophlebitis. No, I would differentiate between both. For me, again, when I get like thrombus like this one, extending to the common femoral, I'll treat at least for 45 days. If I come and find it still there, I'll go for 3 months. I'll treat like DVT. But again, I don't know. I mean, some people, I say there's nothing wrong. Some people, they go only 45 days, you know. But, some people, yeah.
Sorry, sir. In thrombophlebitis, if it extended more, is there any role for ligation of the great saphenous vein?
No, I don't think so. No, because anticoagulant is very, very aggressive now. It's like a DVT. Why need to ligate it? Like if you have a DVT, we don't even put a filter, right? So no, I will not. I will just treat it with anticoagulant 45 days, and that's because the risk of embolization PE is very low, really.
Dr. Samir,
and even if PE happened, this is very small vein, small clot. What's a big clot? So saphenous vein is very small. It's not like a femoral vein, iliac vein. But even if you get emboli, for me, it's just a very small clot. So I don't think it's any important.
Dr. Samer, the question if am I treating for superficial thrombophlebitis, let's say it's more than 5 centimeter, and I start the anticoagulant for 45. And I repeat the ultrasound, I find there is extension of the thrombus to be near for the saphenofemoral junction. In this case, do I need to change the anticoagulant, or in such a case I will do ligation of the saphenofemoral junction just to make sure that the thrombus is not extending more, as I already started the anticoagulant, but the patient coming like resistant to the anticoagulant or something? What do you think?
Not really. I mean, in this situation, I'd be concerned about what the causes are, So I may look for malignancy. I'd be more concerned. The clot is not my concern. This situation, my concern, why it is happening to him. So I will work him up for, especially young people, for malignancy. Why he having extending thrombus, So I will work him, or he's hypercoagulable. So I will be more aggressive in studying to know what's the cause of the thrombosis more than treatment. And cancer is a big issue, especially young people. So I will look really hard for cancer. I'll send him for hematology, for thrombophilia workup, and then I treat him like DVT. Then I'll become aggressive at treating him like DVT.
Do you think, Dr. Samer, is a safe answer to say that I will ligate the saphenofemoral junction as the thrombus is extending, and I'm worried about the more extension of the thrombus? Do you think it's a safe answer to say ligation saphenofemoral junction?
I know, I never did my life, so I don't know really. Is the book saying that?
Actually, this question came in the exam.
Oh, really?
Yeah.
And what was the answer? You have to ligate it?
No, this is a controversy. We didn't know what is the right answer, but
that's a stupid question between me and you. No way. But I'm saying, I mean, the only problem I was that it just make me feel that if you ligate the severance vein, it make you feel that you solve the issue. For me, the issue is to find why he got it. It's more important. You see, if you tell me just ligate it, I'm going to feel that you ligate and just forget about the patient. I may have a cancer and then he died from cancer. So for me, if this happened, I'd like to hear from you. Tell me, no, I want to know why it's happening. I want to work him up. Hypercoagulable, look for a cancer. I want to know why this is happening. You see, more than treatment. Because for me, anticoagulant is enough. I mean, if it's extending, what's the big deal? It's like a DVT. Sometimes you have the whole femoral vein is thrombosed, and we treat him as DVT. So why have to ligate it? Why are you all worried about it? I don't know. For me, it doesn't make sense to ligate the severance junction. I don't know. I will not. So I don't know the answer, but I will not ligate it.
Okay.
Fair enough, sir.
I don't think in the exam you get something like that, so don't worry about it. I doubt you will,
They bring it in the last year, Dr. Samer.
In the oral?
Yeah.
Wow.
Then nobody knows the right answer till now.
Well, just go and ligate it. There's no problem with ligating. Okay, ligate it. What's the big deal? Tell him I will ligate it, and then I will look for the cause of the cancer.
Okay.
I mean, it's no harm from ligating. I mean, the problem, if you don't ligate it, then he wants you to ligate it. But if he doesn't want you to ligate and ligate, what's the big deal? So ask the ChatGPT, maybe answer. I don't know. But I mean,
لا
ask him.
but honestly Dr. Samer يعني your answer يعني is logic يعني if we treat a deep system with the anticoagulation,
Right.
why we are afraid from the superficial system?
From severance, I don't know. But what I'm saying is the problem is people sometimes they read it somewhere or somebody writes something about it, and I don't know.
No.
But if it came the exam, ligate it. What's the big deal? If you think he wants you to ligate, just ligate it.
I have a question, Dr. Samer. It's away from the FINA side. Do you think they will ask us about the CREST 2?
No. They have no time for that. No, CREST 1 and CREST 2, trial, everything. No. In the oral exam, they don't ask about trial and everything. No. Okay. Because no time. You see, all these questions should be answered like in 10 minutes. So quick, Okay. This is the type of question you get. So what happens, the examiner have something like exactly what I have now in front of me, 10 questions, and I have to finish them. It's quick. It's not the time to tell me what CREST 1 and CREST 2, what's about it, Unless if you get yourself to trouble, then yes. If you tell me, okay, I don't want to do it because CREST 2 said that. Okay, I tell you, okay, what do you know about CREST 2?
Okay.
See? That's why I keep telling you, don't volunteer information, Just answer questions.
Yes, agree.
Then that answers the question, and that's it. Don't try to impress them. Try to get off the exam and pass. It's not a time to
Yes.
impress anybody in the exam.
Yes,
Your aim
correct.
to pass the exam, not to go impress him that I have a lot, I know a lot. No. Or I
Okay.
read a trial or read something. No. Just go in, out, like a patient. Get him alive off the table. That's your priority. So you write to go exam to pass, not to
Yes.
impress anybody. Okay.
Yeah, I agree. Thank you, Dr. Sabri.
All right, guys.
Thank you.
If you need
Appreciate
more
it.
lesson, let me know. We can meet Monday.
Yeah,
Think about
sure.
it, guys. If you want more something to talk, let me know. Okay.
Okay.
Sure.
Thank
All
you,
right,
Dr.
guys.
Sabri.
Take care.
Monday,
Salam.
would like to Monday would like to discuss about
Okay,
that.
just tell me what subject so I know, and then we can prepare that. Okay.
خلاص يعطيك
الله
العافية
No
دكتور
problem.
سابر. السلام
جزاك الله
عليكم.
خير. شكرا لك.